Hey guys, so it is what time? Almost 9 o'clock tonight. It feels like Groundhog's Day a little bit. Just redoing this. Feels like I was just here doing this yesterday. So anyway, for you probably saw my news forum. Something has screwed up. They can tell how many minutes I taped. They have the full tape. We can't access it. So here we are again. All right, so we're going to start, pardon me, we're going to start with the pituitary. So you remember when I started out, I talked to you about the endocrine system and how we cover pituitary, thyroid, parathyroid, adrenals, and pancreas. And that all of them contribute in some way to your growth and development, to your reproduction, to your general homeostasis. So you know now how we take one at a time. All right, so how do they function? You have hormones that target certain tissues and they recognize it by receptors. So under normal conditions, they're going to bind to specific receptors. They're excreted in small, predictable amounts, and they're regulated by a feedback mechanism. So we need the feedback mechanism to work for this to work throughout the body. So there's simple mechanisms. I talked about your negative one, which is kind of like your insulin and glucose. One goes up, the other compensates. If it gets too high, it shuts the other one down or makes it more utilized, well utilized so that it stays even. Your heat and air kind of does the same thing. And then a positive feedback is more like your oxytocin. A woman is in labor and oxytocin's released. She delivers right through to the postpartum stage, the afterbirth, and then the oxytocin kind of dissipates eventually. All right, so the first one up is the pituitary. You'll remember I pointed out to you, it's pretty much in the center of the brain. So it is kind of straight back from the top of your nose, very close to your optic chiasm, which is right here. Here's your pituitary down here, your hypothalamus stalk and condylobulum. And for a very small gland, it has a huge responsibility, master gland in the body. It's a very tiny gland, fits on the tip of your finger. And the anterior lobe, which is this little, it is kind of delineated. You can see it delineated. You find my mouse here and I'll show you. It looks like an anterior and a posterior lobe here. I've seen some taken out in surgery that it's just one little thing. You can't tell the differentiation. But it's, so your anterior houses your FSH, LH, your ACTH, TSH, prolactin, and growth hormone. And when I was going through all my anatomy and sciences, they told us to think of flat peg. You know, it's FLAT, PEG. The E that is not here, Lewis doesn't really talk about, and it's for endorphins. That's where endorphins come from also. Now the posterior lobe is smaller, and it's nerve tissue that extends up from your hypothalamus, and it has a big role also. And we deal with ADH and oxytocin, and we will focus on the ADH piece of that. These are primary tumors up to 20% of the time. They are definitely intracranial tumors. They are brain tumors. Patients will tell you how it's not bad. They're going to go up my nose and sniff it out. It goes up your nose, all right, but it's brain surgery. It's right in the center of your brain. All right, so here's your graphic. You can get off of any search engine. It's on, this one came from Bing. It's on Google, it's on any of them. And it just breaks down, if you're a visual person, breaks down more detailed picture of what hormone does what and where it is, where it comes from, if you need that. All right, so the first one we're going to talk about, we talk always in endocrine about too much or too little. And you got to learn one way. If you learn the too much one, you know, and get it down pat, you'll be confident when you attack the too little because it's pretty much the opposite function. So I told you yesterday, break it down into pieces. If breaking it into 5 separate glands is still too much, then break it down to the too much in the one gland and then the too little in one gland and then move on like that. Okay, so anterior pituitary disease, really what we're talking about is acromegaly. This is an adenoma. Adenomas arise from glandular tissue, and it's typically benign. and it produces an overproduction of growth hormone. Now you have flat bag hormones. You have an arrangement of them to choose from, but what it targets is growth hormone. For some reason, this is acromegaly. So it's enlarged, and acro is at the top, so it refers to your pituitary being enlarged. So it causes an overgrowth of bones and tissues. Why? In the child, in the normal, healthy, growing person, you need growth hormone, and it's going to stimulate your bones and your tissues, and your body grows that way. In adults, you don't need it that much. So what happens is the epiphyseal plates on the end of our long bones seal, probably between 17 and 20 years old. And so you don't grow any more than that. Once you're 20, if you go back and saw a marker on the wall of how tall you were, you're probably still that height. You know, people don't tend to grow after that. Some do after 17. I've seen people grow, have spurts after high school even, but by 20, not so much. So now we have this overproduction of growth hormone. Well, your epiphyseal plates are closed, so your long bones can't get long. And where's your tissue going to go? So it gets thicker. You get thicker bones. Your hands don't have epiphyseal plate. Your feet don't have epiphyseal plates that seal. So your feet can get longer, bigger. Your hands can get longer. Your head size gets bigger. Your bone structure around your face gets bigger. Soft tissue growth. You'll see big, coarse folds in people's faces. And so that's where you see it most often, is hands and feet and face. It's other places too. We'll talk about that in another slide. So it's rare. Chances of you getting it, you know how we all think we have everything when we're in school that we study. The chances of you getting it are very slim. It's identified mostly between 40 and 45. And it doesn't mean that that's when it's there, but that's when it's found. And it can be, it's a very slow, insidious kind of growing thing. And unless someone knows you, a physician or whoever your caregiver is, who takes care of you routinely, they won't pick it up. If they don't know what you look like 3, 4, 5 years ago, they don't see the change in your features right now. So it can take a while for this to be picked up unless you develop other symptoms related to it. Okay, it hits male and female equally, so there's no female hormone influence in here. In children, they can still have it. They can have an adenoma, and it oversecretes growth hormone, and it's going to make them tall, tall, tall. And I told you all yesterday about an example that when I first moved to this block, you know, I have sons who are always out looking to play sports and do things. And, you know, depending on how many people you needed to make the team kind of thing, they'd go out and find that many people. I mean, they had each other to start, which was a pretty good start of a team. But, you know, after that, they'd go out and collect people. So I was walking my dogs down on the cul-de-sac, and I see this kid from behind, and he's easily 6 foot. And I thought, well, this is good. I'll go meet a neighbor, because, you know, you Charlotteans are very friendly. And, you know, up in New York, you do that, and they look at you, look a little crooked, like, who's this person talking to me? What are they up to? You know, they're going to scam me on the next corner type of thing. So I figured I'm going to practice being a Charlottean, and I was walking the dogs, and I said, hey, you know, how are you? I'm your new neighbor. And he turns around. This kid didn't have front teeth. He was so young. He had freckles all across his nose, no front teeth. And just looking at him, and he was so excited. Can I touch your puppy? And I mean, he was so 8-year-old, it wasn't funny. And I said, sure you can. So I talked to him, and he told me they had lived there for a while and whatnot. Now, I don't know why it wasn't picked up in this child. Turns out he was 8 years old when I met the mother and all of that. I don't know how they didn't pick it up sooner. Because you know how they chart your growth when you're going for your pediatric visits. So I don't know how they missed it or why they didn't intervene or what happened. But, you know, even both his parents, once I met them, are not tall. It's not like somebody could look at them and say, well, that child's going to be tall anyway. You know, is 6 foot tall when you're 8 years old? I mean, it's a little tall. So anyway, it's unfortunate for this child. And it's hard on them because your lungs are not keeping up with the expansion of your bones and all of that. It's hard. It gives them a lot of problems. So he had a lot of joint pain and all that. So of course he wouldn't have been able to play a sport anyway. But anyway, it's gigantism in kids. In adults, it's acromegaly. All right, adults have a higher risk of colon polyps and colon cancer. And you remember I told you that take your colon, for example. People have the gold standard for colonoscopies is 50. And they pick that number because we know it takes about 10 years for someone who has an adenomatous polyp, a polyp that has grown up out of tissue, to become cancerous. So they screen you at 50 with the hopes that they'll find, if they find polyps, they can snare them. And then you do follow-up colonoscopies more often. And this way they're preventing you from getting colon cancer because they're finding them when they're still adenomatous polyps before they've had the chance to become cancerous. Now, if there's a history of something in your family of someone who had colon cancer early on, they're going to bump you down. The great case is always, I think it's Katie Couric, whose husband, Jay Monahan, died at 40. He was a high-powered attorney or something, died at 40 from colon cancer, maybe 41. So her girls are going to get screened much earlier than that because obviously he was a young diagnosis. All right, so if it's going to overgrow tissue and bones, one of the places we see it is in the colon. So their risk for adenomatous polyps and for colon cancer is greater. Other places we see problems, what are they? Hands and feet, I've told you about. Now, I'm from the north originally, not that you'd ever know by my Boston accent, right? And what did I used to find with these patients? And I've had several over time. It's very rare, but you know, I've been at this a long time. And I've always worked in teaching hospitals, and that's where they're going to come. So they'll tell me when I ask them, they'll say, well, I always wore a size 8 glove, and now, you know, some man would tell me, and now I can't get my fingers in a size 8, so I have to wear a size 10 glove. Or the same thing with their shoes, you know. And up north, I think it was maybe a little, I won't say easier, but one of the things you could say are, you know, our weather is so distinctly different season to season. So in the winter, everybody wore hats when it got freezing cold. Everybody wore boots in the winter because you're plowing through snow all the time. You know, you didn't go out in sneakers and whatnot and try and navigate across the snow like we can do here. So people knew on a yearly basis, these boots don't fit anymore, they're much smaller. So they would have that frame of reference. They knew about gloves, they knew about hats. Men who had fixed felt hats, you know, the brimmed hats, knew because it wouldn't go around their head. So we had that frame of reference to go by, but that's a hallmark for them. So they have proximal muscle weakness. Why is that? Proximal is closer to you. And it's because as the hands are growing and the feet are growing, it's putting tension when they go to walk on muscles that aren't used to that. So we do see that. They get an enlarged tongue. It alters their speech. They find it difficult to talk. Some people think they're having a stroke, and they go in and someone evaluates the fact that their tongue is enlarged. The people that I have had who have been trached from acromegaly have come into my unit, my ICU, because of airway obstruction, you know, until they get this growth hormone under control. So the women, not just the men, tend to have deep voices, and it's hypertrophy of the vocal cords that causes that. It also gives them sleep apnea, and they don't have to be heavy. Most people that have sleep apnea are overweight, middle-aged, you know. These people might be middle-aged, but they don't have to be overweight, and they have sleep apnea. What else? Visual disturbances and headache. I showed you on a couple of slides ago how close this pituitary site is to the optic chiasm. They can also get a headache because there's a tumor in the brain where it doesn't belong. There's no room for it. So they can have that like dull kind of constant headache type of thing. Their risk of atherosclerosis is greater. This relates to the fact that in normal children who need growth hormone, this is how growth hormone helps you. It's going to release fat, deposit fat, and release fatty acids because children will need that. You know, they're growing. They need padding for the organs. They need body mass to them. So it's going to deposit fat, but it releases fatty acids also. And in an adult who doesn't need the fat deposits or the fatty acids, it's going to increase your risk of atherosclerosis because it's got to deposit the fat and fatty acids somewhere, right? So that's another risk to their health. And this and the colon cancer and even their glucose, which I'll talk about in a second, increases their risk of death. You know, it decreases their life expectancy. 5 to 10 years is the estimate. So another thing it does, it antagonizes insulin. When something antagonizes insulin, it is fighting against it, right? So it's not letting your insulin do its thing. As a result, it's raising your blood sugar. So in raising your blood sugar, every person's body has still a check and balance with that. So even if you have this, there should be other mechanisms your body's saying, well, wait a minute, the sugar is getting quite high and it should do something about it. But we find when there's a tumor secreting growth hormone, it can't suppress. We won't see the growth hormone suppress and we won't see the sugar come down. So let's talk about this on the next slide. Well, here's the pictures I was telling you about. You can see some change. I don't know if you have these on your slides at home, if you took pictures of them. They're in your book. They're side-by-side pictures of women, 2 women, who have evolved over the years with acromegaly, and you can see the changes to the brow bone and to cheekbone and the deposits of soft tissue. One picture has a woman with hands in the picture, but it only gives us one picture like that. So it's hard to know, you know, how her hands were in comparison. But it's a good, if you even Google pictures of before and afters of people with acromegaly, you'll see the difference. Okay, so what do we do for diagnostics? We'll talk about this blood sugar thing. So they do a history and physical, and they draw plasma growth factors. This is called IGF-1, LGF-1, you might hear it called. It's insulin-like growth factor. This is released by the liver because it is stimulated by the presence of growth hormone. So the growth hormone gets secreted, even in a normal child, growth hormone gets secreted, the liver will release this IGF, and that will cause the body to grow soft tissue and bones and all of that. So they can draw just growth hormone levels and see where they are. The thing is, when it's an adenoma that's driving it, the secretion isn't constant. So they might catch at different times of the day, high and low, but they will draw growth hormones just to see what they're finding. So they can draw that, but they can do this IGF. And you shouldn't have high levels of this as an adult because you don't need that. You don't need your liver telling you to grow bones and tissue. Now, the other thing they do is the oral glucose tolerance test. So you learned about this in maternity, right? We found that gestational diabetes is the cause of stillbirths. So they give you the OGTT. It's the same thing. You go in, you drink this 75 to 100 grams of glucola, this sickening sweet Coke syrup stuff. It's disgusting. And they give it to you a certain time in your pregnancy to see if you have gestational diabetes. It's gross. So you drink it down, and then they do vital signs and urine and all of that. 30, 60 minutes. They do blood sugars, they do urine. 30, 60, 90, 120 minutes even. So they do the same thing here, because what's happening is the growth hormone is stimulating the IGF and the blood sugar. It's all these things are happening in the body. On top of that, the blood sugar is high because the growth hormone's antagonizing the insulin. Now, if we do this OGTT, that's enough sugar on top of anybody's high sugar level to shut down the growth hormone. It should be enough to say, all right, growth hormone makes me release some glucose, but enough already. Now it's too high. It's my second check and balance. The problem is it's a adenoma that's just secreting it and secreting it and secreting it. And it's outside this feedback loop. It's an aberrant source. So it doesn't matter. Even if your insulin is trying to fight it, it's too much. It's too much secretion of this growth hormone. So they'll see that the growth hormone level does not drop from what it was prior, and we kind of rest the blood sugar. It remains high. So then they'll go doing the MRI, the CT, whatever they have to find your tumor. And they'll do your optic exams, all these little things to see really how impactful this tumor is to the rest of your senses. Okay, so collaborative care. Let's get the growth hormone level down. So we can do surgery, we can do radiation, we can do some drug therapy. It's going to depend on how old the patient is, how sick they are, how severe the disease is, how long do they think you've had it, that it's really this progressive, how impacted you are, and the kind of shape you're in to handle the treatment. That's really what it comes down to for anything. So, therapies. Surgery is probably the one that's going to eradicate it the most because it's going to take away the adenoma. So they do a hypophysectomy. Now they try and do a partial. They want to go up, if they're going to crawl up into your brain, they want to take something off your pituitary. They're trying to limit collateral damage. Let's not go in and, dig around and render everything useless when it's the master gland in the brain, that takes care of everything in the body and affects so many other organs. So what we do know is they can go up and snip out the tumor if it's a reasonable size. If it's too big, they have to wait and radiate. But they can go up and snip it out. It's going to decrease the growth hormone level. That will decrease your IGF. And by monitoring those levels, we can see how it's coming down. If it's a big tumor, and by big, I don't mean gigundo, I just mean bigger than the space it's sitting in, they might radiate it first to make it more manageable because it's a very, very tight spot they're dealing with. So they try and make it more manageable first. Now, if they have to, they do a total hypophysectomy. If this tumor, we don't know if it's going to be web-like or what it is. If it's infiltrated into the gland and they're trying to snip it out and they find it's just infiltrated, or in cutting it out, they've damaged vasculature or nerve stimulation, something to the point that the gland is not good, they have to take the gland out. So now you have someone who has, total loss of all their hormones from the pituitary gland, anterior and posterior. And they need lifelong replacement. Now, what we do is replace essential hormones. So we talked yesterday, what is considered essential? Well, your ACTH, your glucocorticoids are essential. You can't live without them. You can't respond to stress. You don't have immune function. You don't have anything without them. They help your metabolism. You need steroids for your body to work. You can't live without thyroid hormone. So you have to have that replaced. And the other one that is key is sex hormones. And this is because people, I told you yesterday, people are human. Humans have sex. And so it's a quality of life issue. So we're not going to just say, well, too bad, so sad for you. This is a 40, 45-year-old person. You can have sex till the day you die. You could be 100 and have sex. So, it's in the frame of someone's context of living and in the frame of their lifespan, who knows how many years they have left to live. This is something that it also supports their homeostasis. There's a lot of organs that depend on a little bit of your sex hormones, your androgens, your estrogen, your testosterone, all of that. So we don't do well without it. So that's what they consider essential also. Okay, so here's the picture I showed you of how they do this brain surgery. Now here's this long trocar they use. And I told you yesterday, they cut the columna, the little, this little column between your nose and your lip. They cut it here at the bottom and they pull it back over your nose. And if you've seen the skeleton, this is just cartilage. So they have space to go up your nose and work. Now, they have this long tube going up one side, and through the other side is where they're, suctioning and taking things out and cauterizing, whatever else they have to do. What else? So the nose is filthy, dirty, gross. We know that. Up in your sinuses, you can imagine the cilia in your nose that take care of filtering things and all of that. So they do rinse out the cavities and all of that, but you're still taking an instrument like this and going all the way up through someone's sinus into the brain, which is kind of a dicey proposition. Now, if you look over here, it's a more blown up view. This is how it goes up through the sinus. It goes through the front of the sphenoid sinus, which now we have bone patches that they can put like a super glue type of material in there. It's not super glue, that's not what we're using, but it's like that. And they go up through the back of the sphenoid bone. And then the pituitary sits in this little curved thing here. I told you it's the sella turcica, you probably remember from anatomy class. And it's It means Turkish saddle. You know, that's what the camel saddles look like. So it houses it. This is a normal one supposedly down here. And this is the only space it has to live. So you can imagine when it's tumorous, how it's going to push back. This is pushing back into space because it can't fit in the sella turcica here. It's pushing back into the brain. It's going to give someone a headache. It could give you more than that, irritability, seizures, anything. So they're going to go up here, go through the front of the bone, through the back of the bone, try and snip it out. What do you suppose the space is they're dealing with? This thing is magnified for sure, but to get up there with little tiny utensils and be working in a space like the sella turcica is really pretty unusual. It's very delicate, very difficult. And you're causing irritation and bleeding and all kinds of things. So they seal up the back of the sphenoid, they pull this out, they seal up the front, and they take it down. Now, I've had many patients who have had these for one thing and another, and years ago, before they had bone patches, they used to leak cerebrospinal fluid, which is a dangerous thing. You're gonna get a horrible spinal headache, and you have, obviously, if the fluid can come out, you still have an open access to the brain, which is very dangerous. The person could get encephalitis and die, meningitis and die. The options aren't too good. Well, now we have this patching, so we see less of it, but leaking cerebrospinal fluid is always a concern when you've gone into the brain. All right, let's go to the next slide. So therapies, what do? We can do radiation. So it's for non-surgical candidates. It's for people who need to have a smaller tumor prior to surgery, we've talked about, right? Stereotactic, we can do multiple angles and do all that. It's very specific. The treatment can take forever. So it can take months and months and months and months at a time. They don't want to burn you with radiation. They don't want to burn your brain with radiation. They give a radiation treatment stereotactically, and then they wait sometimes to see your next evaluation of a scan, what that tumor looks like. It can take a long, long process. What else? Even if you just have radiation, radiation is zapping the tumor that's in there, but there's no control over the radiation to say, I mean, stereotactic gets us as close and specific as we can probably get. But there's nothing that says it's not burning the next tinge of tissue over, which just happens to be part of your posterior, or it's part of your ACTH, or part of something else. It's a very nebulous division up there. So you're still going to get hyperpituitary or pituitarism if you're just having radiation treatment. It's a real risk. So they're watching all your labs all the time. Now, you can have drug therapy with or without radiation. You can have it, you know, just because it's adjunctive. You can have it neoadjunctive, so you get it before you have the surgery. It all depends on the patient's case, and it's not up to us, you know. So what do we give you? Octreotide. Now, we've talked about octreotide before. It's an inhibitory hormone. We talked about it with cirrhosis. It's inhibitory, and it works to decrease glucagon, and it decreases blood flow among the splenic circulation and the organs. That's how it helps with cirrhosis, but it also decreases growth hormone secretion. Now, that can help a little bit, maybe, not a lot. Think about the fact that what's really causing the secretion is an adenoma. So they can do it, they can maybe, I've seen it more successfully used, and it's not up to me, it's my little straw poll of my world of people I've had with it. But if they've taken the tumor out, they're not sure they got all of it, and they're still giving you some octreotide because they're finding you still have some IGF and whatnot, it can knock that out. It can handle small leaching like that rather than control an adenoma. An adenoma is outside the feedback loop. But they will try octreotide because it is inhibitory. Now, we can do lanreotide, the cistamatulene depot. Anything that is a depot is slow released. So this is an IM injection. And the thing about lanreotide is it's a somatostatin analog. It's our version of what somatostatin is that comes out of the body anyway, out of your pancreas. So lanreotide is an option. Someone can take injections of that. Bromocriptine, this is paralleldel. We use this also for Parkinson's patients. because what is it? It's a dopamine agonist. So that's how it helps Parkinson's patients. But in being a dopamine agonist, it's also decreasing growth hormone. So that helps too. What else? Somavert, that's pegvisomant. I don't know if you're familiar with these drugs at all. This one acts a little differently. This one is going to block IGF production. So even though it's being stimulated by this adenoma, your liver is saying, I don't want to know. So that helps. At least we're mitigating that release of IGF, which is spurring all that bone and tissue growth, which helps. Okay, so here's your stereotactic frame. We looked at this picture yesterday. These are drilled, the connection sites are drilled into the brain, and then they put the frame over you and screw it in, so that when they put you in this linear accelerator here, that metal frame here is snapped into, not snapped, but it's placed in and screwed down in here, and your head can't move. So if they're trying to zap, you can't go to itch your nose and move your head at all. You are locked in this frame. And that's why when they get so specific then with computer guidance of where they're gonna put your radiation beams, it's about as close as they can get. Okay, so what do? Assess the patient. This is a patient who has a brain tumor, and they need their vision checks and they need their neuro checks done acutely, accurately. If we're talking CSF, if you're seeing clear rhinorrhea, and I mean clear running out of the nose, it's always a possibility it could be CSF, even with bone patches. I've seen people having transsphenoidals who are in their 80s and osteoporotic, and you run the risk when they're drilling through those sinuses that, you know, the bone is cracking and whatnot. So we don't know. You can't ignore what you're seeing in front of you if someone has clear drainage out their nose. A thing in the last, I want to say 15 years they've tried doing is putting what they call a balloon-tipped catheter up the person's nose after surgery for 24 hours, all the way up to like the sphenoid sinus. Now, the thing about this is it's basically a Foley. They call it a balloon-tipped, and they'll say, put a insert balloon-tipped catheter or maintain balloon-tipped catheter, and it's a Foley they're putting up there. You see the little access for the balloon and all the, sometimes if they only have a three-way, you can see the port where it has to go out to another thing that we're not using. So, but the point is they're trying to put a little bit of counter pressure if they suspect there might be a leak. Regular run-of-the-mill rhinorrhea. I told you yesterday, if you're out on a real cold day and your nose is running and it's just clear down your face, you probably have 10 milligrams per dilutional liter of glucose. It's not much. If you have cerebrospinal fluid, it's more like 40 to 70 of glucose. That's considerably more. If you find clear running down the nose, now remember, they flushed out the sinus and the nose before they do the surgery. So sometimes they have runny nose, but we're talking running nose, like it's a continuous kind of thing. They'll swab it and send it to the lab, capture it and send it to the lab, because anything over 30, they're gonna assume is CSF, anything over 30 for glucose. So it's just one of those things we watch for. They can also have spinal headaches. If they're leaking fluid, that will be another key, because their spinal headaches are horrible. They're just whomping headaches. And then we'll start assessing them for meningitis. And the key thing for that is nuchal rigidity. Their head won't move an inch up or down. So elevate the head 30 degrees. This is usually by physician order. And the point being, if we sit them up 30 degrees, there's less pressure on the sella turcica, on that little spot that holds the pituitary gland, and so there's less headache for the patient. What else? We try not to get them to bear down. Anything in nursing that we look at says avoid Valsalva or anything. We're trying to avoid pressure, intrathoracic, intracranial, whatever it is. And so here they're saying no Valsalva. Now it's really hard to tell someone not to cough, especially if we're giving them incentive spirometer so they don't get a post-op pneumonia or an atelectasis. So they take a deep breath, they typically want to cough. But what we're trying to avoid is something that really, if they're coughing that bad, we'll get a cough suppressant. not to make them keep coughing, to give them increased intracranial pressure. So sneezing, you really can't control, especially as they flush the nose out. We're hoping they don't have a lot of sneezing to do. The nose has been pretty much cleared out, but they might. But Valsalva, we can control. Let's make sure we have them on something that's going to make sure they poo so they're not straining. Okay, hormone replacement. Watch all of the levels they're drawing. Watch your lights to see if they're out of whack. And the big one we have to look at too is the urine output. Because if there's collateral damage to the posterior pituitary, which there could be, it's a tiny little gland, it could sit on your finger, then we could really screw up the ADH, and we're going to see it in the urine output. We'll talk more about that when you start watching the tape on this tape when it's up on ADH. Okay, so oral checks. We look in the mouth, make sure everything's okay. We can swab carefully. They do not advise aggressive toothbrushing. Some doctors will say 7 days, 8 days, 10 days. They all have their thing. They can swish with mouthwash. They can use swabs, do all of that, but no aggressive brushing. And I told you there was a time when they used to do them up through the palate or up under the gum. And we don't see those as much anymore. All the ones lately that I've heard about are all up the nose. Okay, so radiosurgery care. What do you do if they have radiosurgery? Well, they're at a specialized center. They have to be able to put them in a stereotactic frame and do all this stereotactic radiation, and not everybody has that. So in the meantime, they need pin care. All these spots in their head where one end of the connection has been burred into the brain, you have to keep that clean. And the pin care will be written very specifically of what you have to do. But their hair is dirty. So they usually cut all around that area, shave wherever the holes are so that you can try and keep them clean. But they need pin care. We don't need them to get skin infections. We don't need to get them infections in their skull. They need good pin care. So they can go for a multiple or a single session. Usually it's more than one. One isn't going to do it enough. I say that. There might be a human being out there that's the case, but most people have a series of them and it's over many, many months. So watch the vital signs, watch the neurosigns, and we don't do things in a perfunctory manner. I've said this many times in class. You're not a good nurse if you're doing things just to check them off your list. Nothing becomes that routine. There's a reason for this. And you have to guard against saying, oh yeah, I had to do neurosigns on the half hour and I did them. What are the neurosigns telling you? You won't pick up on a subtle change unless you're focusing on what the data is telling you. That's how we connect the dots. So you have to pay attention to these subtle little changes you might be seeing. Fluid status is important. A loss of ADH can be an issue. Cerebral edema can be an issue. You know, you're looking for spinal headaches, if they're leaking fluid, you're looking for irritability, seizing, nausea, and vomiting. You'll remember we've taught you that with increased intracranial pressure, you don't typically have nausea. The people are sitting there and all of a sudden, blip, and it just comes up. My experience has been when I worked in neuro ICUs is that it's projectile. It's like not just blip in their lap, it's blah out there. So, and that's an indicator. But these people have had surgery. And anytime with a brain tumor or anything else, you add surgery to the mix, they've had anesthesia, they can be nauseous. So I told you with brain tumors, don't tell yourself, well, it can't be intracranial pressure because they're nauseous. If they've had surgery, they're allowed to be nauseous and still have intracranial pressure. You know, the nausea will not discount that if surgery is in the mix. So assess them for that. That's what we're watching for. Lifelong adherence if they're on replacement hormones. They have to take the essentials. They have to. So we got it. That's teaching on our end, you know. All right. So let's look at hypofunction of the pituitary. So we talked about too much. Now it's too little. This is a rare disorder. And it seems in this class in particular, we're always saying, well, this is rare, this is rare. But this is theoretical approach to medicine. You have to hear about it anyway, even if it's rare. And if you work at a place like Maine, that's the kind of a medical center where all this rare stuff comes to. I remember I had students up on the transplant floor in 152, and every single semester we had somebody with calciphylaxis. This is a very rare condition, if you look it up, where they get deposits in the muscle and the tissue. And I would always take them because I'm thinking, when is this student ever going to see this case in their lifetime? I mean, it's rare. And you're going to see it in the renal failure population for sure. But the amount of cases we had here, every semester, I had one or two, the students could go in. They would hollow out from the thigh, strip out muscle and tissue all the way down to the bone and do these big packing dressings. And I would say to the student, have I got a dressing for you today? Come on, come on, come on, come see this. And they were shocked to go in and find it was right to the bone. And I would have somebody look up calciphylaxis and tell us about it in post-conference. You don't see it really. But to have that much of it concentrated in the area that everyone got a chance to see it, so these things are rare, but at big medical centers, you'll see them. That's where I've seen some of the most interesting stuff ever, is at big medical centers. So anyway, this is a rare disorder. You sometimes see it that it's one hormone that's off, and that's selective. You have hypofunction of the pituitary, and it affects one thing. If it's all of them or several of them, it's panhyperpituitarism. So typically, if it's more than one, it's your gonadotrophins, it's your LH and FSH. And people, I told you, don't know they have a problem with this sometimes until they're in adulthood. Maybe a woman who isn't getting her period and she's already been to see an endocrinologist because she's maybe 17 or something, that's abnormal. But otherwise, maybe it's when they're trying to get pregnant. Somebody's married and they're trying to get pregnant, and one or the other will have to go to a doctor and see what the problem is, and many times they refer them to endocrinology. A lot of OB practices in general have endocrinologists part of their group. So we found it's a big thing to look into when someone is having infertility issues. So more common is that you have growth hormone issues. And we see growth hormone issues when I talked about Down syndrome kids, things like that. Okay, so the causes, it can be a pituitary tumor. It can be autoimmune disorders. You can have a autoimmune hypophysitis. It can be pituitary infarction. They call that Sheehan syndrome. It's from a really bad postpartum hemorrhage. Women used to die all the time from postpartum hemorrhage. Thank God it's not the case anymore. There's better drugs and better interventions and better monitoring and whatnot. And we know more about postpartum hemorrhages, but they could infarct their pituitary from a really bad, fighting it for hours trying to get someone to stop bleeding. They could have a Sheehan syndrome episode or trauma. So I've mentioned to you I have seen some horrific trauma cases in my life that I've taken care of, these poor souls. And sometimes it's people caught in gun crossfire in the cities, drug deals, things like that, because I worked in New York City. And they would be sent to big medical centers if there was a prayer of saving their lives. So sometimes it's people that were beaten with something, just hitting them, rendering them unconscious wasn't enough. Somebody must be super angry and just pounds and pounds and pounds, and all the bones are broken in their face. Sometimes it's an unfortunate soul who's attempting suicide, and they put a gun to their head and it doesn't go through and kill them. And they wake up several hours later, but maybe the whole front of their head is blown off or something. So in that case, there's trauma that has destroyed or disturbed pituitary function. And as I mentioned, as much as we're doing airway breathing circulation on these terrible traumas, no one involved in that case is missing the fact that there could be pituitary destruction, because this patient won't live long if there is pituitary destruction and we're not addressing it. You can't live without ACTH. And in a horrible physiological stressful state like that, your body demands steroids. And if it's not there, the patient's going to die. So It's not lost on people who are working on severe head traumas, and it's certainly something they evaluate when they're scanned. Okay, so hypopituitarism, what do we see? It's anterior pituitary deficiency, and it can lead to end organ failure because we said these are essential hormones, right? So lack of TSH, you can't live without thyroid hormones. So all of a sudden you don't have anything stimulating them to release. That's the problem. It could be you don't have ACTH, you can't live without cortisol. We'll get into adrenal diseases and we'll go over that. These things are life-threatening. Even the idea that without ACTH, if you have impacted release of adrenal hormones, you're impacting aldosterone. So people go into hypovolemic shock, and you take these traumas I'm talking about, they're bad enough on their own, and everyone's zoned in on their head and trying to figure out what's wrong. You could be in hypovolemic shock. You don't have aldosterone, you're not retaining water, you're not holding on to sodium, you're depleting potassium. You know, that could kill somebody just on its own. So what do you see? Well, symptoms are going to vary. And we say that a lot too, I know. But here's why. Because it's a space-occupying lesion to begin with. We know you have this issue if you have a tumor, let's say, right? So there's a space-occupying lesion. Well, from that, you're going to have headache. You could have, look at how close it is to the cribriform plate. It's right by your optic chiasm in the bottom of your ethmoid. So maybe you don't have a sense of smell anymore. It's causing irritability in the brain if it's a tumor. So now you're having seizures. And so that's a different picture. If it's not that space-occupying lesion, if it's that you're hypo-functioning because you have low growth hormone, well, that looks different. Now we're talking about the Down syndrome profile that I've told you about, that they have truncal obesity, they have decreased muscle mass, they have a very flat expression, they fatigue easily. If it's the FH and FSH and the LH we talked about, maybe the couple's trying to get pregnant and they're having trouble. What is it in women? Menstrual irregularities. Maybe it's a decreased libido. Maybe it's a change in their secondary sex characteristics that point out to them something's wrong here. You know, what's going on? In men, it's testicular atrophy. It's diminished sperm count. So they're trying to get pregnant with their wives and the sperm count is really low. It could be impotence. It could be, you know, decreased facial hair. All of a sudden their secondary sexual characteristics are changing. So it depends on really what's low and how it's presenting and what the person's issue is. So low ACTH and cortisol, we kind of touched on. Cortisol plays a part in your immune system. You have, you know, decreased resistance to fight any infections. You have diminished secondary sex characteristics here too because of the androgens it plays into. They have weakness and dry skin and, you know, any part of the body that cortisol feeds into and supports is what's off now because you're hypo. And the low TSH is really what we see in the hypothyroidism disease that we'll talk about, that people are really cold. They don't have metabolism that's heating anything up. They get cold intolerance. The bowel is sluggish, so they're constipated. They're tired all the time because it's just dragging. The metabolism's low, so it feels like they have no energy, lethargic. They have weight gain. Now, I pointed out when I was doing this lecture, it's not the people that you see that are grossly obese on television that say they have glandular problems. Who knows? They may have some type of glandular problem when they're, you know, 600 or 800. I worked with morbidly obese people. They were down the end of my hall when I first worked in Boston. They were doing the first gastric bypasses in Boston. And it was not the banding, of course. This was the Roux-en-Y, the one where they really resect your stomach and your intestines. And those poor people, they were sometimes, I mean, they had to take them in on forklifts and weigh them on scales in the kitchen. And I mean, we had to chain two beds together. They didn't have big boy beds then like we have now. And it wasn't historically all that long ago either, but it sounds like it's back in horse and buggy days. But it's, so these poor people are just, you know, and they would say, well, I must have glandular problems. Well, you could be taxing any of your glands being that size, but that's not why they're 1,000 pounds. That's not why they're 950 pounds. If you have a deficiency in your thyroid hormone, you're probably 10, 15 pounds they'll give you because it slows your metabolism, but they're not giving you several hundred pounds for that. Okay, so what are our diagnostics? Well, we're going to do an H&P and look at you, you know, and see what we have. They'll do an MRI and CT again if we're looking for tumors. And we target the different hormone levels. That's what we do. We can capture all of them. The treatment, if you have a tumor, we're going to go up into your sphenoid sinus and take it out. If it happens that we damage the gland enough and there's a problem, then, you know, they're going to give you lifelong replacement of those hormones. You can't live without them. Again, if you need radiation for something, maybe you had radiation for too much hormone and it's now rendered you in a hypo state. But if you have a tumor that's blocking, you know, stimulus or synthesis or anything in your pituitary, they're going to zap that tumor. They're going to get rid of it, or they're going to zap it with radiation. So radiation is always a possibility. Okay, so disorders of the posterior pituitary. These are probably a little more interesting. We said in the posterior, you have ADH and you have oxytocin. So the oxytocin we don't deal with because you had that in maternity. Oxytocin is going to come out when a woman is approaching labor time. It's secreted. It's the positive receptor feedback. And it stays then through to help the uterus contract and all of that. Sometimes people need help. And, you know, we hang Pitocin, which is man-made oxytocin. But so we can support them that way if they need it. If they have boggy uterus or something like that, we can do that. But we're focusing on the ADH because that's what we see in adult health. And the two we talk about are SIADH, the syndrome of inappropriate diuretic hormone, antidiuretic hormone, and the diabetes insipidus. So let's take one at a time. Okay, SIADH is the one that's too much. Now, what makes this syndrome inappropriate is that your body is secreting antidiuretic hormone when you don't need it. Usually, your body will sense shifting circulating volume. It's very smart, your body. So if somebody, God forbid, shot you and you're down in the street and bleeding out, believe it or not, as part of your compensatory mechanism, yes, your heart is beating faster because it's trying to circulate blood. Your pituitary is releasing ADH because it's sensing you're losing blood volume. And so it's going to secrete something to help hold back fluid in the kidney. This is not a time to let all the fluid going out of the kidney be processed and make urine. They're going to hold it before it becomes urine and put it back in the peritubular capillaries. So you understand the body works with that kind of mechanism. This is a person with normal intravascular volume. They don't need the ADH release. They don't. They have normal kidney function. They don't need the kidney to do anything. Don't stop making urine. Urine's a go. Let it go. It's fine. So what does this abnormal release do? It does what releasing ADH does. Causes fluid retention. It causes a low serum osmolality. Why? Because I just explained to you that if it's holding back fluid in the kidney, it's not letting it go to the distal tubule to be urine. It's holding it back. I'm all the way down in the kidney. You have millions of glomeruli, all these nephrons in your kidney, millions and millions. I am looking in the little glomerular unit and all the workings, tiny, tiny, tiny workings, how it comes through convoluted tubules and all these things. It has peritubular capillaries. And if it's not going to the distal tubule to make urine, it's being reabsorbed in the peritubular capillaries. If it goes into them, it's in the vascular space. It's already being brought back into the vascular space to do its contribution of providing fluid to to the vascular system. So if your lights are normal, and then you have all this ADH being secreted, and you're holding back all this fluid from all the nephrons in your kidney, then it's all fluid coming back to the vascular space. This is not a person who's getting puffy with third space fluid. This person has the fluid going into the vascular space. So if your serum sodium was normal, it's not anymore because there's more fluid being added to the vascular space, diluting it. So that is lowering your serum osmolality. Your osmolality is just a term for the relationships of solutes to solvents. So we try and keep your serum osmolality. When you're checking your orders and looking to say, what's my patient's serum osmolality, and then what IV is hanging, so I know they're speaking the same language, you're looking to keep an osmolality between 275, 295 milliosmoles. So that's like a normal range. But this is diluting what's in the vascular space. So it gives you a dilutional hyponatremia. And with sodium goes chloride. So you have a low sodium, a low chloride, low sodium and a low chloride. And you have concentrated urine. If that patient, if they're conscious, and if you needed a UA, you couldn't pay them to give you one. I mean, if they pass anything, it is so concentrated, it's like orangey gold, it's so concentrated. It's shutting down that completely to hold back fluid. So that's inappropriate. We don't need it to do that. It's going a little bit overboard. All right, so what would cause the body to do this? The body's so smart. Why is it acting like this? Because the most common cause is malignancy. Well, this is horrible, but cancers are like that. Adenocarcinomas, up from glandular tissue, from the tissue, right? Adenocarcinomas. Small cell lung cancers, nasty. Pancreas, lymph, colon, prostate, could be ovarian. Even blood cancers, leukemia, lymphomas. I have people with lymphoma with it. So any of those, because it places, when you have disease cells like that, it can put control of ADH outside the normal feedback loop. So they're disease cells, they're acting aberrantly. So that's on its own. Then there's things like infection, lung infections especially, TB and pneumonias and what else? People with bad infections like HIV, you know, that really attacks the body. You can get a pneumonia from AIDS. So things like that affect it. People with COPD, it can put the inflammation alone can put the control of ADH outside the feedback loop. I mentioned positive pressure breathing, ventilation in my lecture yesterday. And this is because, what do you know about PEEP? It's going to increase intrathoracic pressure, so it decreases your cardiac output. And in doing that, you can't forget your little baroreceptors that are inside your atria. You have them other places. You have them in your carotid. Excuse me, I tried to eat something. I haven't eaten all day. I tried to eat before I started taping the lecture, and it's killing me now. Okay, so you have the PEEP is going to increase your intrathoracic pressure, so it decreases your cardiac output. You have these baroreceptors other places, in your carotids, wherever. One of the places you have it is inside your atria, right as the fluid, the blood is returning and entering the heart. So what it senses in somebody who has PEEP, and it's raising the pressure in the thorax, and then it's decreasing the cardiac output. And it raises the pressure, decreases the cardiac output. Your body's reading that as a change in blood flow return to the heart. That's one of the normal, natural trips for you to release ADH. If your body senses that venous return to the heart is diminished, release some ADH and get us more fluid on board. That's just the way it thinks. So that's going to happen here under a false set of circumstances. We're controlling this person. We're probably trying to get them to breathe and be healthy, you know, save their lives. You know, here they are on PEEP, but it will adjust their cardiac output to a degree that baroreceptors will be sensitive to it. So we know this, and we watch this in people that have PEEP. What else? Adrenal insufficiency. If you have adrenal insufficiency, one of the things you have a lack of is aldosterone. If you don't have aldosterone, you don't have sodium retention, you don't have water retention with it, you have depletion of potassium and hydrogen ion. So your body is sensing there's a drop in retained sodium and water. And what's it going to do? It's going to secrete ADH. So it can be renal insufficiency that causes it too. When it's malignancy or it's a disease process, it's usually chronic. And it's difficult to manage for somebody, you can imagine. All right, so other causes. Head trauma. My goodness, you know, these things can be limiting, self-limiting, because let's say you have an embolic stroke or you have a bleed, you have a hemorrhagic bleed, you got a big clot up in your brain, God forbid, and they go in and they remove it. If we can get rid of that clot, we get rid of the need for this. And so the SIADH goes away. If it's you know, somebody that's been pummeled over the head with a baseball bat and their skull is like a puzzle piece, you know, everything's just cracked in pieces, and they can go up and take the shards out and put a plate in and get you all squared away. When your brain restores, all that annoyance goes away. It's good. So that's kind of self-limiting. Other things like meds is not as easy to deal with, even though we know by some of them, if we take you off of them, it'll stop. But some people need those drugs more than others. So can we take you off of them becomes the question. So let's look at a few. I went over this with you yesterday. Let's look at the chemo, the general anesthesia, and the opioids, right? So you might be a cancer patient. You've had neoadjuvant therapy before your surgery. So you've had chemo first. Then you have surgery, you have general anesthesia. Now you're in pain and they're giving you opioids. That's like 3 things here that can cause SIADH to secrete. So that can be a complex case. We're watching for this in people. Oxytocin, not so much. By the time we use it for people, it's usually, you know, maternity is short bursts. It's either to help them with induction of labor or it's to help them afterwards so they don't hemorrhage. They don't have a boggy uterus. So, but look at our psych drugs. This is our tricyclics, SSRIs, right? So this can be a problem here. And then they have to change your meds rather than have you live with SIADH. And people don't like, if they found the med has been good and it helped them, they don't like the idea of coming off. The other more unusual one is this use of thiazide diuretics. Now, I talked to you about every drug we give. Why do we hammer you to say, what is the drug being given for? Why is your patient getting the drug? There's consequences of every drug we have to look at. So we should, if we give even Lasix to somebody, Lasix is a loop diuretic, right? And it's potassium depleting. If we give this to somebody, we should be looking to see the output reflects the action of the drug. Similarly, we give you thiazides. This is hydrodiaryl, hydrochlorothiazide, diaryl, you know, thiazide on its own. So this is a different class of drugs. So likewise, we give you thiazide diuretic. You have to assess your patient for the effect of that thiazide. So you're going to go and see, are they peeing? Sometimes they don't. And the thing is, in some people, thiazide diabetics have a paradoxical effect. If in the renal excretion, it's increasing renal excretion of sodium, that's going to cause a decrease in your glomerular filtration rate. So your GFR goes down, and what is your body saying then? You know, it's not gonna, it's by the time it increases the proximal tubule reabsorption of water and sodium, because the body's saying, well, wait a minute, we're having a problem here. You know, we've dropped our sodium and now we have all this output, we can't have this. So it works the other way. It's not in everybody, it's not in every case, but it's something you gotta keep on your radar. So we don't just say the patient had a little fluid overload or the patient had a little peripheral edema and the doctor ordered them a thiazide and we gave it to them. You gotta be sure it works. You know, we got to assess that to make sure it's working. It was traditionally an old drug to be given for first line for essential hypertension. So people would come in with marginal hypertension and they would say, try a little hydrochlorothiazide. And what they're doing is just reducing circulating volume. It's not the first line therapy now. Usually calcium channel blocker would be something like that. But, you know, amlodipine or something. But when they used to just give you the diuretic, it's really not addressing the issue either. People would still eat salt and still do whatever and just take their hydrochlorothiazide and think it would take care of their blood pressure. So it wasn't a good treatment, but you'll still find people on it for that. But you have to assess that your thiazide is doing the job of a thiazide and not that your patient is the one having the paradoxical reaction. Okay, so issues with meds are self-limiting if we can take you off of them. But if you're a cancer patient who still needs to have chemo, might need another surgery. You know, I had a brother who had thyroid cancer that I talk about sometimes in my thyroid lecture. He had multiple surgeries, multiple. So, you know, every time you're bringing them back to having cancer, having chemo, having surgery, having, you know, it's all this repetitive kind of stuff. And there's a lot of patients like that out there. So you have to think about that. Okay, let's see. Where's my cursor gone? Onto my other page, apparently. Okay, got it. All right, so let's go over the pathophysiology of SIADH so it stays straight, okay? If you start studying, you get confused, come back to this and look at the pathophysiology. So it's an increased production of antidiuretic hormone when you don't need it. You have normal kidneys, you have normal intravascular volume. So that makes it inappropriate. Now, what is it going to do? Giving you ADH, it's going to increase water reabsorption in the tubules, right? So it's going to increase your intravascular volume. And by doing that, it's diluting the solutes there. It's causing a dilutional hyponatremia. That decreases your serum osmolality. So that's your hallmarks of your SIADH. Okay. What do you see? If you're watching a patient, this could be any patient you have develops SIADH, and you haven't known it up till now, so instructors or nurses you've worked with haven't expected that you're picking up on all these subtle signs because you didn't know, but now you know. So preceptorship's a little different, you gotta know. All right, so low urinary output. Why is this patient not peeing? Increased specific gravity if they have a UA, or you work in an ICU, you're in an ICU that has the manometer that we measure it with. Increased specific gravity, what's that all about? Why is there concentrated urine? Increased weight gain. Do your daily weights on your people. It's very, very important, and we couldn't make it any easier than putting the scale in the bed. Hit the button, that's all. Do your daily weights. You will see increased weight in a patient that has no edema. This is not third space fluid. Okay, initially they're thirsty, which I told you yesterday is not the most intuitive thing in the world because they have low sodium. But remember, the premise here is no one has told the thirst center what's going on, right? And so the thirst center is waiting for signal from the kidney. The kidney is saying, you know what, we have no output. Tell the brain they better drink. And so it makes you want to drink and drink and drink and drink. Now, these people, when they're thirsty, will drink anything. I've told you they'll take a vase of flowers on the window, they'll take the flowers out and that horrible water in there, drink it down. It's the only thing they get their hands on. They could go to a sink, they usually don't. I've seen people in the toilet drinking the non-potable toilet water. You've got to watch these people. The majority of mine were unconscious, and so I didn't have that to deal with. But I've seen them on the floors with chronic SIADH, and they're thirsty, and they want to drink, and that's the bottom line. Their families will sneak in anything they can. I don't know why, but I've seen many of them bring the little half cans of soda because they think somehow it mitigates the damage. And they'll say to me, see, it's just a little half can. It's not a full can, a half can. It's fluid. If they're on a fluid restriction, which maybe they're not, but they usually are, they're on a fluid restriction, don't cheat. Somebody's got to be the one that holds the line, and you're the professional. Don't cheat. So initially they're thirsty. They'll have dyspnea on exertion. They're just short of breath. Why is it hard when they go to do something? It's hard. Well, they have more circulating volume in the vascular space. That also gives them a headache. They don't feel well. They're tired. They don't feel good if they're conscious. They're telling you that. So they can have muscle cramping, irritability. They will have an increased BP. So when you're doing your vital signs, what does it mean to you that your patient is having a rising BP? They didn't have it 4 hours ago. They didn't have it yesterday when you took care of them. What's making their BP go up? What's happening? They'll have the headache. If they're conscious, they'll tell you. Now, if the sodium is less than 120, you can have cerebral edema. So they can have vomiting and twitching and seizures and any kind of irritability once the sodium is that low. And you know this. If sodium in the blood is low, what happens? Water leaves the blood and tries to, even out. And where's it going to go? To the cells. It goes to the brain cells. It's going to cause edema. So you have to watch. Your patient can have a lot of neurological issues with this, and it compounds. It starts going pretty quick once you see the initial signs. So you've got it. Your assessments are everything, everything. Okay. So diagnostics. When we measure urine and plasma osmolality. Now, serum, Lewis is telling us, is less than 134. She says that because that's like your low marker. 134, 144, 135. 135 is basically your sodium. So I've seen people, I've had them in the ICU, they're 117. I mean, they're really, really low. If they were conscious, they would probably have an impending sense of doom. That's what they have with real low sodiums. Serum osmolality she's saying less than 280. I get it. It's usually less than that. But she's trying to say if 80 is like the mid-range, it's less than that. It's on the downside. Specific gravity of urine. You have heavy urine. Might as well be gold, never mind liquid gold. It's 1.025. I've seen it 1.030, and that's the highest we measure it. It's heavy urine. Water is 1.0, so that's pretty heavy for urine. All right, so the serum osmolality is lower than the urine osmolality. Now, you don't need to know urine osmolality levels, but just FYI, in comparison, your average urine osmolality is probably 500 to 800, If you have a random one, let's say we just go to somebody and do a random osmo, it's probably 300 to 900, depending on the patient. So, what we're talking about here is the serum osmolality being less than that because it's dropping, right? So they have dilute serum and they have decreased urine output. Classic. The BUN and creatinine are normal. Nothing wrong with the kidney. This is not a kidney problem. Not. Okay. Now, collaborative care. What are we doing? Well, they try and determine the underlying cause, and they're going to, if they find, they'll do med reviews. If they find that it's medication related, they're going to try and change your drugs, get you off of them. If they're meds you take that stimulate ADH, let's find a substitute, get you off. For sodium that is greater than 125, a fluid restriction might be all they do. Now, a fluid restriction is hard for people. I told you, number one, if their thirst is driving them, they want to drink. They might bring it down to 800 a day. I've seen people on 500 a day. So 1,000 is pretty generous, but it's everything. If they're alert and they're eating, it's their tray fluid, it's their IV fluid, it's their piggybacks, it's anything you have to give them in 24 hours. 800 is not a lot, really, and especially in someone who's driven to drink, who's thirsty. So we can do frequent oral care to make them feel better. Don't give them mouthwash to swish, because I'm telling you they'll swallow it, and you don't want to be drinking mouthwash. Don't do that. Don't give them a cup of something. You can use the swabs we have. That's fine, you can do that, but don't give them those little toothette things that have the sponge on the end. You know what nurses do, they put 10 in a cup and put a cup with half water and they put them on the edge of the table. That patient will either drink the water that's in the cup or they take the toothette and suck it dry. You gotta account for the water. If they're on a fluid restriction, you gotta maintain it. And I've had nurses say to me, I feel so bad, the poor lady was crying, or the poor guy was crying, his wife was begging me, so I just gave him a cup of ice. Ice is water. Ice is water. You have to account for it that way. And if he doesn't have, or she doesn't have that many mils to spread over 24 hours, don't waste it on ice they shouldn't have. There's piggyback meds they need. So it's not that you don't understand, it's not that you don't empathize, but that's what you have to tell people. It's not healthy. It's not helping their situation. It's going to make it worse. We have to adhere to the fluid restriction. Put your signs up everywhere. Make sure your techs know. You know, if you're lucky to have a tech in the ICU, they have some at Maine. I'm always so surprised we never had techs. But, you know, tell your techs, tell all the techs. People have to know. Don't give them fluids. Don't. Not if they're on a fluid restriction. That's up to the nurse to regulate to make sure all the meds are getting in. So be careful of that. So when the sodium is at least 125, they might come along and give a loop diuretic and try and kick that kidney a little bit. They might. Sometimes it doesn't work, but they might combine and say, let's try a little bit of this. Because if they can get rid of some fluid out of the vascular space, they can even that sodium. So they'll see. You do a lot of monitoring of electrolytes because when one goes out of whack, the others can go out of whack also. So watch the calcium, your potassium, God knows you need them for, especially if they decide to try a loop diuretic, you gotta watch that K. Between both calcium and potassium, you could have real cardiac issues on your hands. And remember the magnesium depletion. Now, I think I mentioned it, I don't know, in another lecture about potassium and magnesium. It's too late at night for me right now to remember when I talked about it, but you can have somebody on runs and runs of K. You've had these people, I'm sure. They're supposed to get 5 runs of K this day on the day shift. Every time you turn around, you're hanging a K and you're taking it down and putting up another one. Great experience for a student to get over the IV thing. You know, you get real fluid with them. But in the mix, they might throw magnesium in there. And nurses too sometimes do tend to get annoyed when they look up a magnesium level and it's normal. But magnesium will stabilize your potassium. So even if it's normal, they're not going to give you as many runs of magnesium as they're going to give you of potassium, because too much mag isn't good either. But if they think it's going to stabilize these runs of K they're giving somebody, then they'll throw a little mag in there. Okay, so collaborative care. What else do we do? There's, excuse me, I'm so sorry, democlocycline. This is declamycin. So I asked you in class, what is this? And it sounded like an antibiotic, and it is. Declamycin is from the tetracycline family, so it's a streptomyces derivative. And, you know, it's good for gram-negative, gram-positive, whatever. You know, I told you about a UTI or bronchitis or something. There's many uses for it. But the problem with it is one of the side effects we know about this drug works great for the bacteria we give it for, but it happens to block the effect of ADH on the kidneys. Not a nice side effect to have for any drug. So what are we going to do? We're going to dust it off and take it off the shelf and say, you know, this person doesn't have infection. If they do, it's not going to get treated with declamycin. That's not what we're looking for. We're going to give this person declamycin because the side effect is that it's going to block the effects of ADH on the kidney. And we could use that right now. So they might pull that declamycin out. Now, is that more teaching for you? Yes. Because if your patient is conscious, even if they're not, if the family is in there, they want to know why their family member is getting an antibiotic, and they deserve to understand the treatment. So you're going to explain to them, it's not for the traditional use of declamycin that we're giving it. It's not a gram-positive, gram-negative. Please God, the person's got enough problems with SIDH. They don't need infection. And you're being careful because you're trying not to cross-contaminate them because I'm going to haunt you all if you infect somebody. But they, you know, they need to understand that this is a side effect of the drug, we're giving the drug for the side effect. And normally, this is why we don't like this drug particularly, and why we're grateful there's other antibiotics that can do its job so we don't have to give it to people. But this time we can use it, okay? All right, seizure and fall precautions. If your patient is conscious, seizure and fall precautions. They're retaining fluid, they have headache, they could have irritability, they could have cerebral edema. We don't know what's coming down the pike. Mine have always been in bed, but they would be unstable if they were up. Mine were unconscious. All right, we keep the head of the bed flat or up to 10 degrees. And it's because, what I talked about before, your baroreceptors in your heart are gonna pick up on the fact that if you sit somebody up, there's a drop of venous return to the heart, especially in someone in this kind of a state, which it might be a subtle change, but it's enough to trip your natural response for your body to secrete ADH. And we can't take that risk with you in this state. So we keep your head back, okay? Turn and position people that we have on bed rest. We don't just let them lie like a sack of potatoes in the bed. They need range of motion, they need all the care. All my patients unconscious all those years, I was constantly working them. Working arms, working leg. You have to do fundamental care to meet the needs of people who can't do it for themselves. That's what we do. So you have to do the range of motion and all of that. Okay, more collaborative care. For extreme hyponatremia, less than 120, like my people, 117, 115 sometimes. It's cautious use of 3% saline, cautious use. They give it very, very slowly. They watch it carefully. They're trying to increase sodium 8 to 12 MEQs, sometimes not even that, in 24 hours. Depends on how sick the person is otherwise, what other comorbidities they have. So they probably have a fluid restriction, 500 mils a day. That's not a lot of fluid, not at all. So think that a rapid shift is never good. A rapid change in sodium can cause osmotic demyelination. It's not good. We give it slowly, slowly, slowly. If we're giving fluid and we're giving sodium, if the cell, you know, when it's too much in one compartment and not enough in another, it's going to shift one way or the other. And so you have to be very, very, very careful. We watch them closely. Chronic SIADH, we can use receptor antagonists. These are great. If you're a euvolemic hyponatremic patient, so what does this mean? This classic SIADH patient, you are euvolemic. You don't have a problem with your intravascular volume. It's fine. So if you're euvolemic and you still have hyponatremia, then they can say, look, we'll go to this. We'll go to Samsca, we'll go to Vaporsol, whatever. And it works well. They're receptor antagonists, and we need that. We need the receptors to not receive the ADH, to try and act like it's not there. So these are good drugs to give. Now, if your patient is comorbid, which most of them are who are sick, you know, they have other issues. If they have any kind of liver disease or anything, we have to stay away from this because your liver can't break down Samsca very easily or Vaporsol. So what happens? We give you a little bit of it. It's going to hang in the body and hang in the body and hang in the body. And it's not going to let this other person with hepatic disease respond to their ADH at all. So, you know, if it can't break it down, it just stays in the stream floating around, you know, keeps circulating every time your heart beats. So that's not helpful. So hepatic disease is a no-go for those drugs. Okay, what else? Let's see, you're not done yet. Of course, you're not done. So gum can help people with their thirst if you give them a stick of gum, but ice chips are water. You have to count them as part of your 500 or 800, whatever this restriction. Weigh your people daily. Don't be lazy. Weigh them daily. Watch the INO. You learned early on about INO. Not so difficult to realize what's going in is coming out or what's going in isn't coming out. So, you know, we need to watch those closely. Supplement the diet if they're eating. They may supplement the diet with salt, and they'll tell these people, put salt on your food. I don't eat salt on my food. It's part of your therapy. We're going to put salt on your food. I mean, some people don't want it. If they're not accustomed to salt, it's difficult for them. We'll supplement the K if they're on loop diuretics, if that's been helping. Teach your patient signs and symptoms of fluid and electrolyte imbalance. It's not something they want to deal with even. But sometimes if you're just explaining to them, if you get nauseous, if you're vomiting, it could be some environmental thing, they have a noro, an echo or something, a virus, but typically in the setting like this, it's probably related to their fluid and electrolyte imbalance. So, and for low sodiums, we always tell them, if you're nauseous, if you're vomiting, if you have, muscle cramps, if you have a decreased neural function, if family notices irritability, they notice you seizing, things like that. Okay, so what do? You're going to assess your patient. Assess your patient. Watch for low sodium levels, a low urine output, high specific gravity, weight gain without edema. That's how you're going to pick it up. Maintain the fluid restriction if your patient is on it. You're not there to be a soft touch. You're not doing anything for your patient. You're a professional. You can't cave. It is what it is. You're not being mean. Sit and explain to the family, explain to the patient. People have to be stakeholders in their health. And that means you have to have the patience to find a way to talk to them on a level they understand that you can get the message across. What else? Watch for signs of hyponatremia, the nausea and vomiting I talked about, the muscle cramps, seizures, decreased neural function. That's important. Teach compliance with treatment. If this is somebody that has to live chronically with SIDH, you got to help them and you got to tell them how important it is to comply, or they'll be in and out of the hospital constantly. It's better they just comply. Okay, so let me pause this for just a second while I get a drink because I'm dry as a bone, and I'll be right back. Okay, I'm back. I had sent them out with an SOS to get me a cold, unsweet iced tea from McDonald's, so it's nice and cold. Thank you for that little break. Okay, diabetes insipidus. So you know about diabetes mellitus. I was telling you just because people always think there's a sugar involvement here. It has nothing to do with sugar. Diabetes mellitus, diabetes means siphon because you have an osmotic gradient that you just pee, right? You have polyuria. And mellitus means honey. It's Latin for honey. So there's a sweet component involved here that reflects the blood sugar. Diabetes insipidus, diabetes is still a Greek word for siphon, but insipidus is Latin for bland. So that's where this comes from. This has nothing at all to do with blood glucose, nothing. So this is a disease caused by the opposite. This is a deficiency in ADH, or it's a decreased renal response to it. So either the kidney can't respond or ADH just isn't being produced. It's the total opposite of SIADH. All right, what happens? The deficiency is going to cause an increased urine output. And when I say increased, I mean increased, like you turn a faucet on, they pee. It also increases the plasma osmolality. Now remember, solutes to solvents, right? So before in SIDH, we were adding fluid to the vascular space. It diluted the serum, right? You got a hyponatremia that was dilutional. Now we're getting rid of all the fluid. The kidney's just pouring. When I tell you Foley bags just fill, the urimeter, forget it. You just dump the urimeter and turn around before you leave the room, the urimeter's full. I mean, it's incredible to watch somebody. They can go up to 20 liters in 24 hours. It's a lot of fluid. So what's that doing? That's increasing the osmolality because all the fluid's gone away and it's all solute, right? So the osmolality is high. Okay, it can be transient or it can be chronic. And it's based on the cause and what's all behind this and the poor people that have to deal with it. It's not easy. Okay, so what are the causes and the types? Neurogenic is probably the most common. and we focus a lot on it. This is also called central. You'll see central DI written in a chart somewhere, or it'll say neurogenic. It's one and the same. So this is impaired ADH synthesis or release. So we're talking, it's central, it's neurogenic. The cause is up in the brain, all right? It's either a brain tumor that's doing it, it's a head injury, my poor patient who was shot in the face, or my patients who have tried to kill themselves and blow their head off, or somebody who's had brain surgery, detailed brain surgery, or somebody that has encephalitis or some kind of really bad brain infection. So any of that can do it. Nephrogenic is now, we're looking at the source being the kidney. This is an inadequate renal response. So what causes this? Well, our psych drugs again, lithium. Lithium's a big one. How many topics have we talked about where lithium doesn't do well? And it really, for people that need it, it's the med that grounds them. It's a go-to med for a lot of people, you know, from behavioral health. And so once they're on it, they hate to come off of it, but they can't let you stay with diabetes insipidus. The other thing that does it is hereditary renal disease. So this was the polycystic kidneys I told you about. That's a hereditary kidney disease. They get like the clear bubbles, that the cyst that forms all over their kidney, and the kidney can't respond well. Oh, there's so many examples of glomerular basement membrane diseases and whatnot. Alports, I think I told you about. That's another one that if people, it's a hereditary disease of the kidney, and it affects other glands as well, other organs as well. But it's one of those diseases that you probably see at Maine. You wouldn't see it at a community hospital, but you probably see it at Maine. They usually find it in kids, and they have it then their whole life. But that's one that decreases response. And otherwise, it's renal damage. I've told you, I've had people that have come from Sing Sing, it's a big prison up in north of New York City, or Rikers Island, that's another one, where they've had shivs. You know, these people, these prisoners don't have any tools apparently, and somehow create these metal shivs anyway, and somebody gets stabbed in the kidney, and now you have bad kidney damage. You could be shot in the kidney. You could be in a bad car wreck and have a lot of kidney damage just by the way if you're not belted and you're thrown around or whatever, thrown out of the car or whatever. So renal injury can do it as well. Primary, we don't discuss in this course. This is the psychogenic one. This is a mental health issue. And they're so, it's almost OCD-ish, like they're so compulsive about drinking and drinking and drinking that they disrupt the thirst center. And literature, well, Lewis tells us it could be a thirst center lesion, which is possible. Anything's possible. You know, it's funny, every time a student has been with me and seen a patient in ICU and I'm talking about something and they'll say, that can happen to somebody? I'm like, well, anything can happen. I don't know, anything can happen. So somebody could have a thirst center lesion, but you really don't find a lot in literature about it. So, and I've not seen cases of it, and that's just my little world. That doesn't mean anything, but you know, it could be that, but typically it's psychogenic. Okay, so what's the pathology here? It's different. So this is a decreased amount or response to ADH. So for one reason or another, the ADH just can't do its job, right? So because of that, nothing's telling the body to stop diuresing. So there's decreased water absorption in the tubules, and it's all going out. All of it is going out of the body. So that's going to decrease your intravascular volume, and that leads to increased serum osmolality. So now you have a high sodium because all the water's gone, and you have a high sodium, and it's excessive urine output. I mean, just, I told you, students will say to me whenever they've been in an ICU someplace, they tend to see it. And they'll say to me when I come around on rounds, Jane, this patient has DI. Just stand here, stand right here. And I'm like, I know. And they're like, no, I'm not kidding. No, I know you're not kidding. I know. But it's the surrealism of it that you can't imagine you're standing here watching a Foley bag fill up before your eyes. I mean, it's just, You'd think there was a faucet. And sometimes looking at the Foley bag, even though it's blown up and distended with this urine, it's so clear, it's like water. It has no color to it. So just standing at the door, if you glanced in, you wouldn't think anything. It's only as you get closer, you realize the bag is full. I mean, it starts quickly too. So what do you see? Polydipsia, they're thirsty, and they have an anatomical reason to be thirsty. Number one, they have high sodium, and that's going to drive you. I told you, when you go out to clubs or bars or something, you sit down, and what do? They bring you salty food. Now, I know we're not using communal stuff with COVID anymore, but they would bring you pretzels or chips or something, peanuts or something, hoping that people that just sit and don't want anything but a drink are going to sit there at the bar and eat something salty, and then they want to order another drink. So high sodium is going to drive you to drink, as is the body's just need, if it's got anything normal, saying, wow, we're losing quite a bit of fluid here. So you're getting real drive here to drink. This one is a little more easily understood. So 2 to 20 liters a day, Lewis tells us. I've never had a DI that only puts out 2 liters in 24 hours, never. I mean, they pour, just pour. You constantly have the graduate under there dumping the Foley bag, not just the urimeter, the bag. So it's lots and lots of urine. All right, they have very poor skin turgor, you can imagine. They're hypotensive. They have no circulating volume. I mean, they really drop BPs. They're hypovolemic for sure. It's all going out as urine that doesn't even look gold, yellow. It's just clear, pale. The intake cannot keep up with the loss. That's a big, big problem with these people. So low specific gravity, Lewis is telling us 1.005. I've seen specific gravities of DI patients be 1.0 water, 1.0. So they have low serum osmolality, it's less than 100. They have, low urine osmolality, excuse me. It's less than 100. And remember, we said the random can be 3 to 9, and the 24-hour might be 500 to 800 normally. So they have low urine osmolality. They have high serum osmolality, and your serum osmolality range is 275, 295, so it's up. They have hypernatremia, and it's sheer water loss. And uncorrected, a high sodium, again, can cause the brain shrinkage because the fluids are going to try and even out. And, you know, the blood does not have enough fluid, and the sodium is out of whack still, and the shifting is going to cause shrinking of brain cells, and it can cause bleeding in the brain as well. So it's a difficult thing. You got to watch this patient. They go bad pretty quick. Okay, so central diabetes, let's talk about it. Its presentation, typically, if it's postcranial surgery, which I would say that's a really common way to have it. But anyway, it's in 3 phases. It's triphasic, and it's pretty clear to see the phases. So you have this patient back from the OR, and you're watching them, you're doing all your checks, you're doing everything, and your urine output's been fine. You know, 60, maybe 80, maybe 60 again an hour, you're doing fine. You're making gold, liquid gold, that's all you want. And all of a sudden, there's an abrupt polyuria. I mean, out of nowhere. They've been fine for 5 hours. You look in, the Foley bag is bursting. So it's that abrupt. So you're like, okay, now we're out of normal land, patient doing okay, we're not doing so okay anymore. So there's an interphase. It can be a few hours later, it can be a few days later, but there's an interphase where it kind of normalizes. But if you still have issues like this, 10 to 14 days out, they're just going to say it's chronic, that this is a permanent situation. Your synthesis, your transport, your release is impaired because you should have been recovered from whatever we had to do to your brain. You know, you're going on 2 weeks out now, and you're still having this issue. So it's not going to be something that's going to straighten out. Now, if it's head trauma, usually it's self-limiting. We'll fix whatever the problem is, and it'll fix itself. But if it's this long after surgery and it's not fixed, then it's probably not going to fix. So nephrogenic can improve if you take you off the meds, if you're, whatever med you're taking is causing your issue, and remove the med, that solves your problem. So that's good. But then you have to find another med that might treat your problem and cover you as well as the last one. And that can be an issue. So, all right, so what's the consequence? The dehydration is the consequence. I mean, you can't keep up with the urinary losses. You can't. And my patients have been unconscious, and it's hard to keep up with them. And I'm controlling them through IVs. But, if your patient's conscious, you're having them drink and drink and drink and drink and drink, and you still can't keep up. Every hour, you're taking more out of their Foley and more out of their Foley, and you're saying, okay, you need to drink another can of soda, you want another cup of coffee, you want another. I mean, it's really hard to keep up with. Patients suffer because they have hypotension, so they get up and they're orthostatic. They're having tachycardia because the heart's trying to compensate. That's not good to leave someone tachycardic. They can have hypovolemic shock. I mean, this is a sick patient, They can you start to see mental changes, as you always will, change in level of consciousness. So they can have anything from just subtle changes all the way to coma. And it's, they're sick people. Okay, so what's the diagnosis? Diagnostics are key, always. What are the diagnostics? So we differentiate the type of DI somebody has. Yeah, they'll do the history physical. It's always a great place to start. But then they do a water restriction test. Now, we teach this in the theoretical approach. So the theoretical approach is we will get baseline weight and urine osmolality and volume and specific gravity, and then hold all the fluids 8 to 12 hours, and then give desmopressin, or DDAVP, diamino-dearginine vasopressin. It is artificial synthetic ADH. Okay, so we give that, and we can give it sub-Q, we can give it nasally, however we're going to give it, we give it to this patient. And then they measure the urine osmolality in an hour. If it's central, urine osmolality increases and the urine output decreases. Why? Because if it's central, the problem was your pituitary. You weren't giving me ADH. You weren't sounding the pituitary's out of whack, and we're missing ADH. So I just gave it to you in your arm, and all of a sudden you're responding. So I know the problem was central. Okay? Make sense? Kind of? No one's here to tell me. So if it's central, think about it again. If it's central, and I give you DDAVP and your kidney responds, then what you needed was ADH, because I just gave it to you in your arm and your kidney responded to it. That means the fault is your pituitary gland, okay? If it's nephrogenic is the cause, there's no response, because whether your pituitary keeps trying to give you ADH and your kidney can't hear it, or I give it to you, your kidney still can't hear it. So it doesn't matter whether I sprayed it up your nose or put it in your arm or your pituitary gave it to you. If it's nephrogenic, it's not going to work. The kidney's not going to respond to it. So that's the difference. Okay. So another differentiator. It's really kind of the same, but a little different. From central DI, from nephrogenic, is that you can measure ADH levels. So if we measure an ADH level before, and then, we give you the desmopressin, and if it's central, then the urine will concentrate because the body responded to the ADH. And if the problem is central, it wasn't getting ADH, and I just gave it to you. I sprayed it up your nose, and now you're responding. And your ADH level has changed. So if it's nephrogenic, it doesn't do anything. Your ADH level will get higher, but the kidney can't hear it, so it doesn't matter. So that's the deal with that. They use the prior page a little more, but I'll tell you, when they do the one on the prior page, I've never in the ICU had a patient, I mean, never is a hard word, never, ever had a patient who could go 8 to 12 hours with no fluid, especially with DI, when you see them losing voluminous amounts of fluid. So even on the floor, can you, in theory, that's the way it goes, 8 to 12 hours. Can you really do 8 to 12 hours? I've seen doctors truncate it on the floor and say, let's give them the next 3 hours. Don't give them any fluid, don't do it, you know. And even that's dicey because they're still pouring urine the whole time. So it's, you know, you got to watch your patient doing tests like that it's reasonable for them to do. You know, you might have to change the times. Okay, so into professional care, what are we going to do? Well, for central diabetes insipidus, we give IV fluids, oral fluids if they're awake. If the patient can drink, let them drink. And we give them hormone replacement because if it's central, we know that's the problem. The pituitary isn't doing it, so we give you hormone replacement and now it'll work and all bets are off and everything's fine, okay? In the acute phase, we're gonna give them a hypotonic saline or a D5, which is kind of sort of isotonic, but as soon as the D5 dissipates, it's hypotonic. And that's gonna avoid the osmotic diuresis. Now, you have to be careful. If someone is getting D5, we're trying to avoid the osmotic diuresis. If you're getting D5 and you can handle it, your body can handle it, and it's not raising your blood sugar at all, it's fine. But if you're getting D5 and you tend to run high blood sugar anyway, now you're going to have a high blood sugar. A high blood sugar increases osmotic gradient, and it's going to make you pee. Not a good idea. So we see them more often go with the hypotonic saline just to avoid that altogether. Sometimes when they're treating patients like that, they don't know their long-term history of how their sugars run. But even if it's normal now, do we want to push that envelope and run the risk of creating a glucose gradient? Probably not. So we're doing CC for CC replacement, hypotonic saline or D5, CC for CC replacement. So let's say it's on the hour. Most of mine, I would say, were on the half hour. They were putting out that much. But let's say it's on the hour. So 11 o'clock to 12 o'clock, I measure your Foley, you put 200 out. There's a designated peripheral IV that is running your hypotonic saline. And if I get, at 12 o'clock, if I get 200 out of your Foley, then I run from 12 to, for the next hour, 12 to 1, I run in 200 of the hypotonic saline. If the next hour it's only 150, then on the hour I run 150 in. So you're changing your flow rates all the time. So that's how we're trying to keep up with the fluid loss until we get some reaction out of the patient. Watch the blood sugars. If you have D5 at all, watch the blood sugars, because if you get a high blood sugar, you're making the diuresis work, and you want to pick up on that and say, I call somebody and I say, you can probably hear me, and I say, do we really want to keep this guy on a D5 additive? Because you know what, we're seeing the urine output is picking up again. You think it's the osmotic, I mean, I don't say it's snacky, but you think it's the osmotic gradient maybe that's doing that? So most times they will take the D5 out of the bag. Okay, now, check the blood pressure, check the heart rate. We don't forget the simple signs. You got to do your vital signs. They're telling you vital details about the person. Check the urine output, check the daily weights. It tells us a lot. Level of consciousness, specific gravity will tell us something, okay? DDAVP is part of our interprofessional care. Why? Because if they need it, if they have central, then they will respond to DDAVP. They will. So it's PO or IV or sub-Q or up the nose, however it's ordered for your patient. But make sure they're getting the dose when it's ordered, not that they're off the floor and you've put it as a missed dose or something. They can't go without it. Can't go without it. The other thing they can give them is chlorpropamide. This is diavanase. You don't hear as much anymore now that we have, metformin and all these other meds for type 2 diabetes and whatnot. But this is a drug they use for type 2 diabetes. And it's an old drug. I mean, it works fine, but it's an old one. And the thing about it is it helps decrease the thirst associated. with high sugars in general, but also in this case with DI. And they don't know the exact method of what it is that does it, but they find carbamazepine is helpful also. So carbamazepine can be used for this kind of thing too, and at least help decrease the thirst that people get with this. But you know, it's an option. It's something they can use. You don't see it every time, but they can. Okay, so what else? Let's see. What's the collaborative care? Well, with nephrogenic DI, we can't give them any hormone because we already know it doesn't respond to the hormone. The kidney is not responding. So forget that. We can give them low sodium diet if they're awake, alert, and they're eating because we can support the sodium, right? What else? We can't support the sodium. What else are we doing? We're giving them no hormone. People can drink. We want them to. Drink, 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 drink. Thiazide diuretics. Remember the reason we wouldn't use it for SIADH because of the paradoxical effect. They might take it out now and say, try it now. Might help a little bit, might. Some doctors are willing to try that. Others are saying, nah, I'm not so sure this patient's gonna, you know, they know their cases, they know their people. Some doctors have an affinity for different drugs, but it's a possibility. Indomethacin is another one. This is an NSAID by prescription. And one of the things it does is it increases renal responsiveness to ADH. So that's helpful. And so they might put you on it. Now, people want to know why they're on an NSAID. Like any other NSAID, they have to eat when they take it, not to get gut rot. And, but it's not an inflammatory process they have. That's not what it's for. And, you know, when we talk to people, it's not enough to explain to them the name of the drug. Tell them what the drug is doing. Because they'll Google the name and tell you, my father doesn't have inflammation, my sister doesn't have whatever. You have to tell them, you know, what the story is behind it so they can accept it. Okay, what else? Assess your patient. That's what you're going to do. Assess, assess, assess. It's signs and symptoms of fluid overload you're looking for. This patient with DI has been so hypovolemic. There will come a time, if you're not watching, that the fluid catches up. And if you're not watching, you could go from hypovolemia to fluid overload. You don't want that. You don't want that. So watch your patient and assess them. They've been hypovolemic and hypovolemic. I know all the days they've been hypovolemic. Today might be the day it turns around. So they've been taking hormone. Today might be the day it turns around. So be careful that we're not still doing the CC for CC replacement that doesn't match the need for it in our assessment data. You know, you have to be able to articulate to physicians and give them the feedback so that we're not putting somebody in fluid overload. All right, watch their BP, the heart rates, the urine output, the daily weights. I've said all of this before, I know. It's important. Specific gravities, INO. Look, vital signs again. Look, daily weight again. It's important. Watch the blood sugars with D5. Watch the blood sugar. We're trying to avoid the osmotic gradient. They've just had all this dumping of urine and we couldn't control their output. And you don't need to raise the blood sugar and start that all over again. So watch that. So that's that. And hopefully I've been coherent. I feel rather incoherent a little bit, but hopefully I've been coherent. If you have any questions regarding content, reach out and ask me in case I'm rambling or something and something you don't understand, okay? All right, guys, have a good one. Bye.